All right, going to start here. Welcome to the review of the O'Connor Hospital Certified Primary Stroke Program Code Stroke Alert workflow. We'll spend some time for the next hour going through the workflow in detail. Here's our agenda. It's quite ambitious, but I hope that you will find it very helpful. And by the way, my name is Karen Della Cuesta. I'm the Stroke Program Coordinator here at O'Connor Hospital. We're going to be touching on all of these items. We'll be describing who to call when troubleshooting the stroke telecart and the downtime procedure. We'll be talking about the difference between contacting the on-call teleneurologist and the local community neurologist. We'll talk about briefly steps to activate the teleneurologist. We'll talk about what the EMS medics use in the field, which is called the GFAST exam, and where patients go based on that score. We'll talk about Target Stroke Phase 3, the national door-to-needle goals, and where O'Connor and actually the Stroke Enterprise is within those goals. We're going to talk about stroke program resources and your Code Stroke Alert resources. We'll review in detail the Code Stroke Alert workflow pit stop for EMS arriving and walk-in patients. We'll discuss the rationale for communicating the estimated time of arrival, or ETA, for those EMS arriving patients as a Code Stroke Alert. We'll talk briefly also about, of course, your last known normal or baseline and time of symptom onset for that Code Stroke Alert patient. I'll ask you to identify 3 signs and symptoms of large vessel occlusion. State 1 action item the teleneurologist must do, which is in your protocol before you could administer the thrombolytic bolus and infusion for that ischemic stroke patient. Also, you'll need to pay attention to the clinical practice guideline blood pressure parameter. What is that blood pressure parameter requirement before you're able to administer your thrombolytic bolus and infusion? And where are we required to keep the blood pressure parameter based on the guidelines post-thrombolytic alteplase bolus and infusion? So with that, let's get started. We are very fortunate here in Santa Clara County to have all of our hospitals stroke certified, which is approximately 10. We have several that are comprehensive that surround us. We have a thrombectomy capable, and the rest are primary stroke centers. So we are very fortunate. All of the hospitals who are stroke certified are required to have stroke services that are available 24/7. And we are required to maintain continual state of primary stroke center certification readiness by the Joint Commission and meet the American Heart, American Stroke Association clinical practice guidelines. And all of these metrics, measures, standards, providing and offering the latest evidence-based care, whether that's permissive hypertension, statin, aspirin, etc., are all based on the guidelines, and those are built into our order set. So that becomes our protocol. So what about the telecart? So here at O'Connor Hospital, we have teleneurologists. They are available 24/7, 365 days a year. The group's name is USC KECK, K-E-C-K. So it's KECK Teleneurology. They are in, obviously, Southern California, if you're from California or not. If you're just familiar with USC, yes, that is true. It's the university or the school. They are on call 24/7. And how the teleneurologists engage with us and our Code Stroke Alert patients is they navigate and connect through the telecart. And this is what you're seeing here on the screen. We have one telecart currently in our emergency department. We have another telecart on the way. That telecart will be a backup telecart that will be located within the inside CT scanner as a backup for you in the emergency room when you have back-to-back Code Stroke Alerts. And also it's a backup cart for our inpatient Code Stroke Alerts. Therefore, the inpatient Code Stroke Alerts would not be utilizing the ED cart. And if you look at this telecart, if you're familiar with the company Teladoc, they actually acquired InTouch. InTouch is the original maker of these carts, and these carts are great. Number one, the cart stays on all the time. We do not turn these carts off. The cart is stationed across the ED charge nurse desk by the bathroom, and you'll see that there. And we always want the cart facing out. We always want to be able to see the LCD screen on the front here. And if you notice on the yellow highlight on the upper left, you can see one of these circles on top of the LCD screen. It says directional microphone, so you know where to speak into clearly. There's also the power button there. And to the right of that other circle, if you will, is the camera on the right, okay? And behind the LCD panel, there is a silver button. That is the power on and off button. If on occasion you are having difficulty ensuring that the on-call provider or teleneurologist does not have connectivity, you can turn the cart off or boot the cart off. But we only do that when it is clinically safe to do and it is appropriate. I will tell you that many of our on-call teleneurologists will be connecting to the cart through their phones, perhaps while they're driving, while they're walking into the hospital, etc. So many of the times a poor connection prompt appears on the screen. It is not coming from the server between O'Connor and the provider. It is likely going to be on the provider's end. How can I know that? Because I've done much interrogation and have figured that out. However, if you do experience problems with the telecart after the code as appropriate, certainly you can delegate to the charge, to the tech if available, or actually even to the clerk to call the technical support help desk here at the bottom, the 877-484-99 number. And the help desk would like to remote into the telecart and interrogate the cart, and they will check to make sure that there weren't any connectivity issues or any server drops to the server through teledoc and then back to O'Connor, and then of course going out to our partnership with USC Keck teleneurologists. Okay, so the cart does arrive with us at the time of the code stroke alert, and we take it with us as the patient moves through the workflow for the code stroke alert, and the cart is put back in the ED. So we have one cart in the ED, we have another cart on the way, but again, nothing to do with the cart. Once the provider connects to the cart, they just appear. So please be patient with them as they get their connections dialed in, okay? And you have a little bit of a table here on the back of the cart, and also in the back of the cart, you see this yellow binder. It actually says Telecart Daily Checklist. And at this time, once a day, the charge nurse will make sure that the telecart is charged battery full. There is this gray box that houses the battery and some other components here on the right. As long as the green bars are all the way full, indicating the battery is charged full, you've got 6 hours plus, you're good to go. Not that your stroke alert's going to last you 6 hours, but you've got a fully charged battery, so you don't need to keep plugging it in once you're in CT scan, even for an extended amount of time for advanced imaging, right? Advanced imaging, what I mean is CTP, meaning CT perfusion of the brain, and CT angiogram or CTA, head and neck. Okay, we call this our advanced imaging. And if we were to add in a non-contrast CT scan head to the other two images, we call that our trifecta of imaging. So the telecart stays on 24/7. The provider will come on screen and we push the cart with this as we go. So if you need to troubleshoot with the audio, I'm on the right-hand side here. You certainly can touch on the LCD screen and increase the volume so the provider can hear us much better. They also have controls on their side, and oftentimes they will wear a headset. So let them kind of get settled in before we need to adjust more. And usually the camera is not an issue. Wi-Fi, this telecart is not connected to the network. It just has Wi-Fi connection, which is to the internet here at the hospital. And it has been mapped to ensure the best signal strength. Had just been rechecked by IT. Sometimes you have to move it around a little bit, maybe, not even a foot, maybe less than a foot. But most of the time, the Wi-Fi at our end works very well. So powering down the cart, only instructed by teledoc. You have to call them in on the help desk to do so. Again, that's the button on the back of the LCD panel. So when you get to the ED, I encourage you that you check out the telecart. If you're unfamiliar with it, have not seen this model before, this is the RP Lite. Okay. Other than that, when not in use, the telecart stays plugged in, the battery is full. We check, the charge nurse checks to make sure the Wi-Fi is connected. You can touch that LCD screen however you like. You're not going to do anything wrong. You're not going to disconnect it. So I encourage you to experiment and investigate and get very comfortable with the cart. If we have any problems, we can call the 877 number. And on the side of the cart, on the body of the cart, I used with a label maker. I typed out on the label maker the help desk phone number for you should you have to call the help desk. And no one has that number memorized. It's there for you on the side of the cart. I also put the teleneurologist pager number on the side of the cart for you as well as a quick reference. And then also part of our code stroke alert workflow process in the emergency department, they also keep 2 IV pumps in the CT scan to be able to administer thrombolytic in the scanner, which is our workflow, which we'll talk about in just a moment. And we also keep a computer WOW dedicated in the inside CT scanner to ensure that you have the ability to enter your patient's weight if you had not had a chance already upon arrival, and also to check your thrombolytic order and anything else that you might be able to do while your patient's undergoing that initial non-con head CT scan. Okay, moving on. So I did already touch a little bit about teleneurology, and I just want to kind of touch more on that. What we use here at O'Connor Hospital, and I apologize if this is repetitive, but we do use what we call MI on call, or MEON desktop icon. This has the call schedule for not only O'Connor, but for the enterprise, and the enterprise meaning O'Connor, St. Louis, and Valley Medical, or Santa Clara Valley Medical Center. So if I needed to activate, or I wanted to know who the local community neurologist is, I would go to MI on call. And the question is, do I need teleneurology? So how do we take care of our patients that have emergent critical neurology needs? We would activate teleneurology. They're available 24/7, 365 days a year. Now, let's say teleneurology is going to work up my code stroke alert patient. However, I have to have a neurologist follow my patient the next day because my patient did in fact have a stroke, and this is the best standard of care. So in addition, I need also to contact the local community neurologist. So what I'm trying to explain here is that when I click on the MI on call schedule, and I pursue the O'Connor Hospital schedule, and I bring up the neurology call panel, I'm going to see 2 options here. One is for who's on call for neurology. That would be, for this example, Dr. Kim Tenzer, and then her pager number is there, and I would activate her through a different vehicle. Now, our teleneurologists, since they're the USC Keck teleneurology group, they are activated through their own internet URL, and that is called TelMed IQ. This is an icon that is uploaded onto the clerk's computer desktop on the main side and on the triage side of the ED. If you haven't seen it, go look for it and watch them activate teleneurology, because you may need to at some point activate yourself, okay, for a code or to help out. And it's also the icon, this URL shortcut, TelMed IQ, is also loaded onto the charge nurse desktop screen on the main ED side as well. So if I need teleneurology, I would go right to the TelMed IQ. I wouldn't even have to look of who's on call because it actually pre-populates, which is great. But let's say after the stroke alert is done and someone was asking me, oh, who's on call for neurology for tomorrow, not teleneurology, then I would go back to MI on call, and I would look to see, oh, for neurology, next day follow-up is Dr. Gupta. Certainly I could give this phone number to the provider who's asking, and they could reach out to Dr. Gupta to arrange that next day consultation, okay? So 2 separate services, teleneurology, urgent, emergent, and also can be for your non-stroke alert patients. Perhaps you have a patient, we have many that come in and are seizing. We very likely will activate TelMed IQ or our teleneurologist to remote in on camera to evaluate the patient, okay? not something that can wait until the next day. All right. What types of exams and what types of protocols do our providers and partners in the field here in Santa Clara County utilize to triage patients to the nearest stroke center? And you touched on this, I believe, earlier during your general health stream module completion. And what I provided here for you is just a snapshot of the most recent protocol of the field assessment of acute stroke for Santa Clara County EMS. And what we're using right now is GFAST. And what it stands for is very simple. It's just what's described here in the gray box. A patient gets a point if they have a gaze abnormality, gaze to the left, gaze to the right. Perhaps they have a dysconjugate gaze and they have kind of a rotational nystagmus. That would get the patient 1 point. They ask the patient to smile in the field. The patient has an asymmetrical smile, a facial droop. That's another point. The providers are going to ask the patient to hold their arms up for 10 seconds. If there's a drift, even a dip before 10 seconds, that's a positive finding. That's another point. If the patient has paresthesias of any sort in that arm, that's also a point. So, you know, a weakness, a paresthesia in the arm, those also are going to be points towards that arm drift, okay? Because it's going to be a decrease in sensation, a decrease in ability to maintain that arm. Speech abnormalities. If the patient has slurred speech, otherwise known as dysarthria, if the patient expresses difficulty with word finding, we call that expressive aphasia. If the patient has difficulty understanding commands, possibly the patient has receptive aphasia, or perhaps the patient is completely aphasic. Those are all abnormalities. The patient would score a point. So if you look to the right, you'll see that the GFAST screening, if you come down to the yellow box, is GFAST score. If the GFAST score to the right is the max, 4 points, the patient will be transported to the nearest comprehensive stroke center. For us here in Santa Clara County, that is Good Samaritan, or Regional Medical Center, or Stanford. Now this is in the field, okay? If the GFAST is less than or equal to 3 points, and this is very important, the patient will get transported to the closest stroke center, primary or comprehensive. Very important here. The higher the GFAST score, the more likely the patient's having a large vessel occlusion of some sort. This is what we're trying to discern here in Santa Clara County. I've been doing this since 2005, and what we used to use is FAST. And for many of you that have experienced stroke scales in your clinical experience, whether out in the field, within the hospital setting, you've experienced them all. The FAST. We also did a study. I was one of the PIs on BFAST. We wondered, gosh, are we missing posterior strokes in the field? We used BFAST in the field, balance and eyes. What we found, a null study. We did not pick up on any missed posterior strokes using BFAST. And then what had happened was really thrombectomy, clot retrieval, right, in the brain, arterial, had exploded. And we had data come out from Dawn and diffuse trials, etc. And what we wanted to know was we need to recognize patients with large vessel occlusion out in the field and get them to the nearest stroke center, meaning a comprehensive or thrombectomy capable for clot retrieval. Hence, the GFAST was born. So that is the purpose of the GFAST. So at O'Connor Hospital, we are a primary stroke center. However, critical that you know on ring down, what is that GFAST score? You should be asking and you should get an answer. The higher the score, the sicker the patient. The higher the score, my more thought process is this patient having a large vessel occlusion, an LVO of some sort? If that's the case, we are going to immediately, hopefully, be able to give alteplase and transfer the patient to the nearest thrombectomy capable / comprehensive stroke center for thrombectomy eligibility, ideally. So not only is thrombectomy or mechanical intervention important, chemical thrombolysis is still equally as important. And many of you are probably still familiar with Target Stroke Phase 3 national goals, door to needle. And we here at the Stroke Enterprise, and in particular at O'Connor, are wholeheartedly invested into the national goals. Why is this important? You've all heard it. Time is brain, time is tissue. The sooner we can get the thrombolytic to the patient at the side of the clot, the much better outcome that they have. And that is the push for door to needle, door to needle, door to needle. Extremely important. So Target Stroke Phase 3 now is saying, really, we should be focusing on 85% of your patients should receive thrombolytic door to needle within 60 minutes. 75% at least door to needle 45 minutes. Where do we need to be? And we've been a stroke center, many of us, since 2007. We need to be 50% door to needle, 30 minutes, and even more than 50%. I would like to see us at 90%. Now, within reason, we know things happen. Can't get an IV, got to bring the blood pressure down because it's too high based on the clinical practice guidelines, puts the patient at risk of symptomatic hemorrhagic transformation. Maybe there's a question about anticoagulation use. Well, is it one of the 10As or is it warfarin? But we have our guidelines here. And to achieve the 30-minute door needle time, it's not easy. But if the workflow is adhered to and we do our proper screening, we can do it. And it has been done, and we are in the process of making great strides here. So what is it? It's door to physician in less than 2.5 minutes, door to stroke team less than 5. It's rapid, door to CT initiation less than 15, and door to CT interpretation less than 25 minutes. That's important. We need to have no blood on head CT scan to help make that all-to-place decision. Obviously, you can't give a thrombolytic to a patient that's got intracerebral hemorrhage, and you certainly couldn't give a thrombolytic to a patient that has a acute, subacute stroke or hypodensity on non-cleansed CT. So we have to certainly look at our exclusion criteria for thrombolytic. But nonetheless, Target Stroke Phase 3, door to needle, 30 minutes, 50% or more of patients. That is the goal for the Stroke Enterprise. So you'll hear that a lot. Now, what about resources, code stroke supplies? So I know that your educator will be touring you around the ED, so be nosy, ask questions, open cupboards, look to see where things are, because that's what you're going to be wanting to do, hopefully before you need them, right? So in the emergency department on the main side, there is a bright pink ED binder located above the ED main Pyxis. And that ED binder has papers and some documents for you related to the ED stroke alert workflow. Also above the Pyxis is your ED code stroke alert box. So once we get the ring down, we get the patient registered, then we're able to pull our stroke kit from the Pyxis. What's in your stroke kit? Alteplase, nicardipine, and labetalol. As we know, it's all about anticipation, getting that patient ready for thrombolytic administration. Okay. I have a typo. Inside the CT scanner, we have a Alteplase caddy for you. It's stored in a label cabinet inside that CT scanner. So again, ask if you're not familiar with it, look around. Also in the inside CT scanner, you will see 2 dedicated IV pumps. One IV pump is for your infusion. The other IV pump is your backup should you need to start nicardipine. Do not waste your time if you have to give more than 1 dose of labetalol. Do not waste your time going to get hydralazine. Do not even use it. In fact, go to nicardipine, because if your blood pressure is already on the high side, greater than 185/110 that you need to lower before your bolus and your infusion, more than likely, you're going to have to restart your nicardipine or give another dose of labetalol, if not already, to maintain less than 180 over 105 post alteplase. So try to think ahead a little bit to help yourselves out. And with that, we've got you 2 IV pumps in the inside CT scanner. Also in that inside CT scanner, there is a dedicated WOW. So when you arrive with your patient and the patient is being scanned, and if you had not had a chance already, that is a great opportunity to log into that computer, enter your weight, and you can verify at that time, do I have my order for alteplase that we talked about at the pit stop? Do I have my order for labetalol, nicardipine, alteplase, as we talked about in triage, as this patient is in the alteplase window? Okay. Or perhaps the patient ends up being a head bleed, an intracerebral hemorrhage, a basal ganglia. We're not giving alteplase, but perhaps at this point, gosh, you've got to bring that blood pressure down to 100 to 140, and maybe they're 180 to 190. So what will you be doing? Starting your nicardipine after your non-con head CT is complete, and you're getting ready, or excuse me, and the techs are getting ready to start their CT angiogram of the head after they've completed the scan. Okay, all about the prep. And then lastly on this slide, we have the HHS Connect. So what we're building is a stroke program website for you, just for some additional resources. It's also required as a stroke center. And what I guess I'm trying to say here is that on the desktop, you would have the HHS Connect icon. Once you double click on that, you get the list of the hospitals within the enterprise. You would click on O'Connor, you get the toolbar here, and on the toolbar, you would read across to the right where it says programs, and then you would left click on programs, and the drop down says stroke program. And that website is being built by myself, and we'll have a dedicated ED folder for you for resources. All right, so this is where we're going to spend the rest of our time talking about the protocol here in the emergency department for stroke alert. Okay, I'm just going to start at the top. So here we are, it's the emergency department, EMS, walk-in, because we still get 50% of our patients walking in through triage with stroke signs and symptoms. We also have patients who will call EMS and or walk in with wake-up stroke. And you probably have heard of wake-up stroke. I go to bed normal for the most part, and I wake up with stroke symptoms. We call that wake-up stroke. I went to bed at 9 p.m. last night. I felt fine. I woke up at 6. I have left-sided weakness. I have left-side hemiparesis. I've got some dysarthria. I may have some neglect. I may have a partial homonymous hemianopia. That's a wake-up stroke. Already you know I'm not going to be able to receive alteplase. We're not at TNK here at this time, but I'm not able to receive alteplase. So I'm out of the thrombolytic window, but certainly you should expect that I would have the trifecta of imaging. What is that? Non-contrast head CT, CT perfusion, because we're looking for core infarct, and penumbra. Penumbra, remember, is that area of tissue at risk to be infarcted. We don't want that for our patient. And also CT angiogram, head and neck, looking for any kind of stenosis, large vessel occlusion. It could be proximal, it could be distal, it could be anterior, it could be posterior. Okay. And continuing on, code stroke alert and LVO, large vessel occlusion / transfer out. Transfer out is very important. At this point, we are a primary stroke center. We do not take patients here. We don't have the ability to take patients for thrombectomy. We do not have neurosurgery on call at this time. We are not required to have neurosurgery on call as a primary stroke center. Our process is that if we have a patient who requires neurosurgical services, we call Valley Medical Center. We ask them to perform a consult, and they make recommendations, and we transfer the patient to Valley and or Stanford at this time. We have contracts with Stanford, Valley Medical Center, and Regional Medical Center for transfer. And let me be very clear here so that you are educated. Valley Medical Center is a primary stroke center. Okay. We are contracted with Regional Medical Center and Stanford University Hospital. Those are the two comprehensive stroke centers patients would be transferred to for a neurological higher level of care. Okay. And these are important notes. They're important because we as a county are looking at, we call our door in, door out times. Oftentimes we are challenged with arranging critical care transport to transport our patients out. Let's say our ischemic stroke patient that we would call a drip and ship. Patient received alteplase here at the hospital. Patient needs to be transferred for thrombectomy at, say, at Stanford or Regional. The longer it takes to get an ambulance rig here to transfer the patient worsens their stroke, meaning that they have got brain cells dying. I know it because I've seen it and I've received these patients, being the director of neuroscience at a comprehensive stroke, and you likely have too, being on the front line, and it is very disheartening. So there is a huge sense of urgency to identify these potential patients early on in presentations and start thinking, do we need to transfer? Do we need to transfer? Do we need to start reaching out now to ensure that our receiving facilities can start looking at images and making treatment decisions as soon as possible? Okay. So the next box here, it states the following personnel will be alerted when a stroke alert is activated. Well, how do we know when to call a stroke alert? Stroke alerts are called, and this is based on the guidelines and the evidence, last known well 24 hours or less. Now remember, there is a time I'm last known well or I'm at my baseline. So when did you last talk to me, or when did someone last see me? Normal. Well, that was at 9 p.m. Well, then my friend called me at 11:30 and I had very garbled speech and I wasn't making any sense. Probably I had expressive aphasia. She was very worried about me last night at 11:30. That is my symptom onset. So that's what I say, 2.5 hours. So my last known well, my symptom onset, so 9 p.m., 11:30, that puts me in the thrombolytic window. What's a thrombolytic window? 0 to 4.5 hours. So I'm a candidate for alteplase. Those are two very important distinctions, and that's what we're always going to try to tease out with the patient and EMS or family and teleneurology for the walk-in patients. Okay. So who responds? Last known well, we activate 24 hours or less. Teleneurologist, we always want to activate them first, because what they'll do is that once teleneurologist gets activated through that URL link by the clerk or the charge nurse, they're going to immediately call back, and they're going to want to talk to the ED physician and ask them, what's the scoop? What's the history of present illness? What's the HPI? They too are trying to tease out information. Unfortunately for the EMS arriving patients, teleneurology is not going to learn anything different than what we learn, but that's okay. Remember, as a stroke center, they have less than 15 minutes to touch base with the hospital to ensure that, yes, we are here and we're going to remote in and we are on board, okay? So very important. So not only is teleneurology activated, they're calling in, they're speaking with the ED physician, radiologist is on board on standby. Your EDR in charge is making sure that a primary, secondary nurse is assigned. The ED tech is zeroing that gurney that's in the stroke pit stop. Right now, it's in front of the ED charge nurse desk for best visibility. The tech is also pushing the telecard into place. We're getting our paperwork together. Our clerk is, I have another typo, gosh darn it. Our AD clerk is making sure that, people are getting calls as they should. We're overhead paging. Very important, if it's an EMS patient with an ETA of 5 minutes, we should be overhead page ETA 5 minutes. The whole team, lab, pharmacies on remote standby, CT scan needs to know if they have somebody on the table, that they have another 5 minutes to get somebody off the table and get the table ready for the incoming patient. If anything, please over communicate. Don't assume that people know, because they do not. Again, pharmacies on remote standby. The X-ray technologist is on standby as well. Again, CT is on standby, phlebotomist, and registration as well. Okay. So how this flow chart works is that it's not as bad as it seems. The top half works left to right. The blue bar separates. And then we go to the bottom, works left to right. Okay, so we're going to start at the upper left. And what I'm looking at here is the walk-in. So we have two scenarios here. Walk-in, triaged patient. You'll be using BFAST for these patients. So you have a patient that comes in, it's in the last 24 hours, and they complain of double vision, diplopia. Perhaps they have a cranial nerve palsy, maybe posterior fossa stroke. Maybe also they have F for facial droop. Maybe their B for their balance is off. So as they start sharing their HPI and their symptoms, you are immediately going to perform a BFAST assessment on them. If any one of the BFAST criteria is positive in the last 24 hours of last known well, you are to alert the ED provider. If the ED provider does not see you and the patient within 5 minutes of request, you have the authority to activate overhead page code stroke alert and immediately bring the patient back to the stroke pit stop, make sure that the clerk or the charge activates teleneuro ASAP, because right now we're already behind the time frame, and that you have this walk-in patient. Okay, we can always cancel, but I will always support you overcalling as opposed to undercalling. And yes, you can write that down, take a picture of the screen, whatever that you need to do. The other scenario is your EMS field ring down. So when we get the field ring down from the EMS providers, we want to know, is it a code 3? What is the GFAST score? The higher the score, the sicker the patient. So I'm thinking LVO, if they're telling me a GFAST of 3, oh, that's pretty bad. And I want to know symptom onset, last known well, and I want to know language. About 34% of our patients that come in, our race and ethnicity is Asian. Another 29% are Hispanic. We have Caucasian. We have Indian. We have quite a mixed demographics. So we want to be able to ensure that we meet our patients' needs, and we queue up our translation app as soon as possible in case of the fact that we actually do need it, okay? And if we can get any kind of COVID-19 screening or status, even if it's a PUI, that is very helpful, okay? So you will have to press the EMS for the GFAST and language, anything else you can get out of them, okay? That is going to better prepare us to help the patient's best outcome. That is our job and our responsibility. So once we get our ring down information or our walk-in information, we are going to certainly activate teleneurology. I'm in the blue box now, activating the code stroke alert process. Typically our ED charge nurse or the ED tech, we're going to over communicate, of course, to the ED physician, simultaneously the EDRNs, to please activate teleneurology. We do have a whiteboard that we're going to be moving. We're going to update that. We're going to put whatever information we have for HPI on the whiteboard, because what happens is that one person has the information, then they walk away or they get busy, and the rest of us don't know what's happening. So we want to write that information on the whiteboard. And again, simultaneously, we're pushing the telecart into place. We're zeroing the telecart, we're zeroing the gurney. We're getting all of our paperwork together, and we're preparing for the patient's arrival. We've got our cardiac monitor, our registrars in queue, and now we're just waiting for our patient to arrive. Once our patient arrives, if our ED doc is not there, certainly we're going to give a shout out. Code stroke alert patient is here. And what's our number one thing we want to know, of course, is our patient, I'm in the red triangle. A, B, C, D, is the patient stable? If they're not stable enough to go to CT, or at this point, even just lay hands on for any kind of focal neurological exam, we're going to room them and we're going to make sure that they're stable enough. We're going to resuscitate them however we need to, and then we'll finish our code stroke alert protocol, okay? And if you notice there, I've got some brief timelines below the red box, like 1 to 5 minutes ED arrival. So let's just say our patient is stable. So we're going to move again to the light blue box that says follow stroke alert protocol. And as you know, many of you have likely worked in certified stroke centers. And at this point, our team receives our EMS walk-in report. And simultaneously, all these things are happening. We're going to make sure we get the weight always, regardless if they're in the window or not, get a weight. And if it's a walk-in patient, if you already got the weight, like a standing scale, if they could state the weight so everybody knows, okay? Again, we want to make sure that we all confirm symptom onset, that last known well. We want to get a list of medications. It's extremely important. The top two that come to mind are what? Of course, are they on an ACE inhibitor? Because now I'm thinking there's a risk for oral angioedema if they are to receive a thrombolytic like alteplase. And my second question would be, are they on any kind of anticoagulants? Because that's a contraindication possibly to TPA or alteplase, right? So the 10As, warfarin is not. Now remember, warfarin, they can still get alteplase if they've had warfarin, but their INR needs to be less than or equal to 1.7 if you look at the new guidelines for thrombolytic administration. Okay, so if I hear the patient's on warfarin, I'm going to ask lab to please run that superstat and call me with the result, because we're going to be in the scanner and we don't have time to keep checking the computer. Okay, so over communicate and make sure that the team knows these pertinents, right? And then the ED physician and the teleneuro MD will conduct a very brief focused NIH. Now you will have some teleneurologists that will want to do a full NIH, spend a little bit more time. It's okay in the scheme of things. In the pit stop, I've got there about equal to or less than 5 minutes. That's the ideal if you get the teleneurologist to come on time in camera. Some of these are going to vary. Now, again, this is just, framework, kind of the overall view. If the patient's consentable for TPA, it is worthy to complete the full NIH at that time, because once the NIH is completed, the team, you as the team members are going to say, okay, look, the 2 large bore IVs are in, we got the sugar, we've got a quick EKG, we finished the NIH, what's the plan? You've got to stop and say, what is the plan? Oh, the plan is, yep, looks like we're going to be able to give some TPA. And what do we want to do after that? Well, after that, we need to do CTP and CTA head and neck. Do not leave the pit stop unless you have a plan, and be firm and engage your ED physician and your teleneurologist. If you have concerns, questions, clarifications, contact me. My contact information is at the end of this presentation, or Janet as well, or Liz. We need the feedback, okay? So patient arrives, we're kind of on the patient, we're weighing, we're confirming, we're getting the details, we're trying to figure, can we give them, can we not give them thrombolytic? If they're out of the thrombolytic window, if it's a wake-up stroke, then that's done. We don't have to worry about that, because now they're excluded and we know why they're not eligible. The other caveat in the yellow box is, now I'm thinking, all right, so how is our NIH stroke scale? Is it equal to or greater than 6? Because based on a lot of the Dawn and Diffuse, the thrombectomy trials, 6 to 10 is around where those patients who do have an LVO are likely sitting with their NIH stroke scale. And what we're learning too from the county is a GFAST score 3 or 4. With what that looks like is hemiplegia, hemiparesis, and a gaze preference. So it can be a contralateral gaze preference. So even if you get a patient that comes in and you're thinking, oh, it could be TOTS paralysis versus maybe a seizure in your differential diagnosis, that's okay. Entertain it, verbalize it, put it out there. These are the things that we want to think about, right? So NIH 6 or higher, GFAST score, 3 or higher. Sometimes we get a 4 because they'll worsen in the rig. That's why you want to know what their score is before they get here. And this is the idea of this is the idea that you need to know the plan and make sure that everyone's on the same page before you go to CT scan. So at the gurney and the stroke pit stop, yes, patient's going to get alteplase. Great. After that, yes, teleneuro and ED physician agreed. Yes, CT angiogram head and neck and CT perfusion in this order, and CT angiogram head and neck. Great. We have our plan. Yes, great. Okay. We're going to leave now with the patient. We're going to go to the inside CT scanner. At this point, the patient would have already been registered, and we would need to make sure that, okay, guys, let's do a quick stop here. We've got to make sure we have our stroke box, and have we retrieved our stroke box medications from the Pyxis, meaning our 100 milligram vial of alteplase, our bag of nicardipine, and our vial of labetalol. Once we have our drugs, we can take our box, our patient, and our cart and ourselves over to the inside CT scanner. While we are en route with our teleneurologist to the CT scanner, our ED physician is placing the orders. ED physician can place the order for the alteplase. That's great. They should. We can always cancel it if we don't give it, if it's a bleed or something else that we see, maybe a subacute infarct on non-con head CT. We want them to put in the order for the CT perfusion and the CTA head and neck. We can always cancel. What you need to realize, this teleneurology group does not put in orders. They are in a view-only mode. So everything that they recommend is a recommendation. And another provider, for example, the ED physician, actually places the orders as they are in agreement, if they are in agreement with that plan recommendation from teleneurology. Okay, so yellow box, possibly, let's just say this patient has an anti-stroke scale of 6 and they have a GFAST of 3. It was on the ring down. Okay. Also on ring down, if we can get language, that's very helpful. And I apologize if I've already talked about that. Luckily, this patient for us, let's say, just speaks English. So that was not so much an issue. But again, the more that we can obtain from EMS, even for our walk-ins, the better, much better for our patients and the better outcome for them. Okay, so now we're off to the CT scanner. We have a plan. So we're off to CT scan. We get to CT scan. We put our patient onto the table. We put our stroke box with our drugs in it on the counter. And under the counter, there is a labeled cupboard that will say TPA Caddy, C-A-D-D-Y. Next time you're in the CAT scanner, I want you to look for the caddy and I want you to pull it out and take a look at it. Everything you need to reconstitute your alteplase and administer it is in the caddy, okay? It's very important that when you get into the CT scanner that you get into the habit of pushing the telecart when you bring it, and you will not bring it all the time because sometimes the teleneurologist is not to be with you all the time while you're in the scanner. But when you do bring the telecart in with you to the scanner, and while the patient's being scanned, you're going to push the telecart with you into the control room because you want to keep the teleneurologist engaged. You're going to have information for them. They're going to have information for you. If EMS is with you, bring them in to the scanner and bring them into the control room. Engage them. And oftentimes they will give you more information, as you all know, that will add to the story and actually helps the teleneurologist make further treatment decisions. Okay. And while you're in the control room and the patient's being scanned, and we have the patient, of course, on the cardiac monitor, we're monitoring airway, you're going to log into that WOW, and you're going to enter the patient's weight if you have not already, or someone else has not already entered the weight for you. This is a great hardwire process. We would have already also acknowledged our blood pressure at this time, knowing that our patient's in the thrombolytic window, right? Our blood pressure has to be less than or equal to 185 over 110. So patient's getting scanned, we're putting our weight into the WOW. We know our blood pressure, let's just say right now, our blood pressure is 145 over 80. So our blood pressure is good. Teleneurology, they're doing their thing, and we're just waiting now while the patient's being scanned. Patient's done being scanned. Now, what you need to do is re-engage teleneurology and ask them if they would like to go back into the CT scanner and examine the patient. While you're talking to teleneurology, the gray box on the upper right, the radiologist now is going to be reading the non-con head CT, and they're going to call the ED physician with the results, and they're going to say, hey, there's a bleed, there's no bleed, it looks fine, maybe there's subacute infarct, whatever. They're going to call that head CT scan to the EDMD. So now the EDMD already knows what the results are. Teleneurology is waiting for that non-contrast head CT to get pushed to the PACS system and then to our Rapid. Our Rapid is our CT perfusion software app that the teleneurologists also look at for advanced imaging results that they can look at themselves, okay? And they're trying to figure out, is a patient alteplase candidate? Is there a large vessel occlusion? Is there a bleed? Is there something else, like maybe a mass or a lesion or subdural, or, you know, it could go on and on and on. So they are also waiting for those final images to come through on the non-con. Simultaneously, they're going to go into the room with you, and you are going to facilitate an efficient NIH stroke scale with the teleneurologist on camera. Now, some of them want us to take the patient off the table and put them onto the gurney. I am not a fan of that. So before I even really begin to even help them with the exam, I will grab a pillow, put maybe a pillowcase over it or something, and I'll put it under the patient's head, trying to prop them up. It's a lot of work to have to take them off the table and back on the table or not. You will get some that will demand it, and we will do it, but it's not ideal, okay? And then you'll complete the NIH exam, and at that time, simultaneously, as we're finishing the exam, the teleneurologist will say, oh, yeah, the head CT looks fine. I recommend giving TPA. Okay, so now we move down here to the red triangle here on the left. This is the IV alteplase. I lost my E. Alteplase here on the left. And look, it says 5 to 10 minutes for the TPA administration. So alteplase yes or alteplase no? Alteplase yes. Protocol is teleneurology has to contact the ED physician to order the alteplase to be mixed and given by you in the scanner. They have to, that's the recommendation, okay? So before you give it, not only do you have to make sure the blood pressure is below 185/110, you agree upon your NIH stroke scale, let's just say of 6 before. You need to also ensure that your teleneurologist has an agreement from your ED physician. Yes, it's okay to go ahead and give. They are in agreement to give the alteplase, okay? So that's very important, because why? Because the teleneurologist does not put in the order for alteplase. They put in no orders. They write no notes within the EMR, okay? They fax their note and they make recommendations, okay? So teleneurology MD contacts the ED physician to order it. So they'll call, they're probably already calling when they're maybe even having a scan saying, yeah, more than likely, I'm pretty sure I'm going to give it. So I'm just going to let you know. But nonetheless, they should have a final conversation. Then you'll say, great, you had the final conversation. Yes, we're mixing. So one nurse is going to start, if not already, mixing the drug. Constantly, you're going to be cycling your blood pressure to ensure your systolic is less than 185/110. And by the way, do not touch the blood pressure until we know what the patient has going on. We always allow permissive hypertension. What is permissive hypertension? It's letting the blood pressure ride up to 220/120. That is the current guideline, okay? So our blood pressure is, what do we say, 145/80, so we don't have to treat. That's good. Number 2, teleneurology, yes, has discussed with the EDMD. And they also said, oh yeah, by the way, I'm just confirming, we're going to do CTP, CTA after the bolus and infusion has been started. And our goal, door to needle, 30 minutes, okay? So at this point, no imaging is going to take place. You're already mixing, we've already got our weight, and you'll be learning with your ED educator how to reconstitute the alteplase, and you'll also be checking against your EMR, your physician's order, that you have the right bolus, the right infusion, and how much you'll be wasting. You'll be using your calculation sheet that you will be using and that you learned in class, excuse me, also. And then you'll do a soft timeout, and you'll have the primary nurse and the secondary nurse. So one will bolus and one will give the infusion. Very, very important. You give the bolus over 1 minute. You do not flush after the bolus. You start the infusion 1 minute, immediately after the bolus, okay? So bolus at 12:30, infusion 12:31, okay? Do not delay. The half-life of alteplase is like 5 minutes. It's very short. That's why you give a bolus, no flush, and you follow it immediately by the infusion, okay? Now, Remember, in the beginning, we talked about 2 large bore IVs. Well, why 2? Well, you have to have one dedicated for the alteplase, and you have to have another one dedicated for the advanced imaging. And what if you need nicardipine infusing? You might need 3. So unfortunately, your poor patient is going to be a little pincushion. But again, these are things that you have to think about. Access, right? So those are some key findings here. The expectation from a teleneurologist. Soft timeout. Dr. Smith, okay, we just recycled the blood pressure. I know it was 145 over 90, but per protocol, unless you agree and you need to document, I'm going to recycle again. And by the way, I noticed the other day when we had a case that the patient's blood pressure was creeping up because she became more and more anxious, and it creeped up to 178 over, I think, 90 something. And I had recycled it, and the physician said to me, no, I don't care about that, just give it. And I said, well, then you need to document it. And then I wrote it down. I had the nurse document as well, right? Because 5 years from now, in a court of law, or God forbid, the patient developed symptomatic hemorrhagic transformation later on in the ED due to her anxiety and her blood pressure creeping up, that would be a concern, and I would not have been able to defend the situation. So don't assume, document your conversations and make your notes, okay? And again, this is for the patient. This is like my family, right? So soft timeout. Dr. So-and-so, the blood pressure this time is 140 over 90. Yes, the bolus is 8 milligrams. The infusion is this. We wasted this much. We're going to go ahead and bolus, correct? Yes, go ahead. Okay, it's 12:30. Bolus in. Great. 12:31 infusion started. Great. And then what will happen is he or she will say, go ahead then, proceed with imaging, and I will sign out and call ED physician. Great. Thank you very much. Have a great day. Teleneurology is off camera. Infusion has been started. And now we'll use the other IV to proceed with, according to this blue arrow, CT perfusion and CTA head and neck, okay? If you have patients, and I'm sure you have, that say, oh, I have an allergy to contrast. Well, what happens? Well, I'm not really sure, but I don't want it. Okay, so then at this point, we would just abort both. And we could go back to the ED. Or what we could do is we could call the ED physician and say, hey, this patient now is telling me, I just learned that they have an allergy. Well, what kind? Well, I'm not really sure. Or maybe it's something vague. So there's a couple options here. Again, abort. We can pre-medicate with IV Solumedrol, 125 milligrams, maybe 25 milligrams of IV Benadryl. I'm not making this up. These are medications per the guidelines that you can pre-treat before pursuing CTP and CTA head and neck, but you're going to have to wait, obviously, right? Like another 30 to 45, maybe even 60 minutes before we can actually pursue the advanced imaging. So at this point, after that conversation, you may end up returning to the ER to wait to pursue that advanced imaging. The other consideration is, and I'm on the gray box here below the blue arrow, is EDMD receives non-contrast CT results of the head. There's no metal in the head. Now, the other option, and I performed this through our standardized workflow at the Comprehensive Stroke Center, was then we would obtain a STAT portable chest X-ray. We're looking for metal, right? So if there's no metal in the head, there's no metal in the chest, we could consider a STAT, if we have a tech, STAT MRI of the brain, and that would be limited sequence, meaning limited sequence of DWI, ADC, and FLAIR. These are just, it's a canned protocol. And also STAT MRA, like MR angiogram of the head and neck. So we just want to look at the vessels. If that is agreeable, we could do that. But again, the order has to get put in, and then we have to be able to do a checklist, right? So not an easy thing whatsoever. And here we're looking for that large vessel occlusion based on the GFAST and the NIH app presentation. Now, we haven't done this yet, but it's always out there as an option. As primary stroke centers, we are not required to have MRI capabilities 24/7. Our current capability is Monday through Friday, 9 to 5, 9 to 7. May need to double check that. I'm sorry, I did not have that just right at the forefront of my brain, but primarily we have a very busy MR department, okay? But certainly this is a high priority that we would escalate to the MR department. Now, if our patient can undergo CT perfusion and CT angiogram, CTA head and neck, post alteplase, then we're going to do that through another IV. Through the alteplase line, nothing is compatible. That's a dedicated line, right? So nothing goes in there. So at this point, then the telecart can go back to the ED. Please delegate your tech or release your tech or release your second nurse. Have them take the telecart back to the ED ASAP for the next stroke alert. Release them if you can. And then advanced imaging will take place. And then once the advanced imaging takes place, then you are done and you can return back to the ED to continue managing a patient until you hear the results on the CTP, CTA. So, is there an LVO, large vessel occlusion? If there is not, as I go down to the gray box, then it's medical management. So we want to ensure that we have the post-thrombolysis order set done, and that would be done by the ED physician and also the ICU intensivist. And then we continue on with, if we haven't already completed the EKG, the portable chest x-ray, the labs, patient's going to be NPO. Certainly you can do the dysphagia screen, but the patient isn't going to get anything while in your care in the ED. And certainly we want to hydrate our patients. Please, we need IV fluids, only normal saline for these patients. Remember, we want to protect the kidneys after all of that contrast dye from CTP, CTA. Most, if not all of these patients are dehydrated when they arrive because they're not feeling well, whether it's not feeling well for the past 2 hours or the past 23 hours. And even patients that arrive outside the code stroke alert activation window, consider hydrating them as well. And if they've suffered a stroke, we still want permissive hypertension. So let's give them some volume within the intravascular space to help allow that permissive hypertension. Teleneurology at this point is, again, closing the loop with the ED physician regarding medical management for the post-thrombolytic patient, and then the ED physician is arranging for admission. Now, if the patient is positive for a large vessel occlusion, this is a game changer here. Immediately, as soon as we have a confirmation, if not already, ED physician should already be talking to the transfer centers for Stanford and Regional Medical Center. Those are the higher level of care comprehensive stroke centers we are contracted with. And they are calling them because they have received impressions from the radiologist regarding the CTP and the CTA head and necks. Yes, there's an LVO. We've got to prepare to transfer out now. We're going to medically manage these patients. Even if they didn't get TPA and we bypass, they're not eligible for, we bypass the alteplase process because they were not eligible, we would just go right to trifecta of imaging, non-contrast, CT head, CTP, CTA head and neck. Then we come back to the room. You're on pins and needles, expecting that, yep, any second, I've got to prepare to help transfer out this patient. As the ED physician is speaking with Stanford and or regional, who's going to accept, how soon can they accept, are they looking at the images, and how soon can critical care transport be here? Now, our critical care transport, we have a few contracts. They are very, very busy groups. If we cannot transfer that patient out within our goal, less than 120 minutes, which is 2 hours, which seems like a lot of time, but sometimes it's not. Here in Santa Clara County, we can and we have and we will call 911 on behalf of our patients. There is a county policy to do so, and it is approved and it is expected because this is one of the county performance improvement projects that we are looking at, very closely, right? How long and why does it take so long for our patients to get transferred to a higher level of care, okay? So the transfer in, transfer out time or door in, door out goal is less than 120 minutes. So you have your patient that you are waiting to transfer out. whether they got TPA or not, you've got a patient with a blockage in their brain. That patient can crash on you in a matter of seconds, okay? So while the physician ED physician is arranging your transfer out, you need to get very clear orders where to maintain that systolic blood pressure. It's just like a clog in the pipe at home. How am I going to make sure that my water is still draining everywhere else in the house and it's not going to back up in the tub or in the kitchen sink or in the bathroom sink or in the toilet, right? Sorry, poor analogy. However, we want to maintain permissive hypertension in the brain. If there's any lack of blood flow to that penumbra, that core infarct will expand due to the clot and the patient's stroke will extend. How do I know? Their NIH stroke scale goes up. Their GCS goes down, right? So maintain systolic blood pressure, 160 to 180 millimeters of mercury. You may need a pressor. We need to find out. If your ED physician is unclear, does not know, they need to call back the receiving neuro-IR physician and get clarification. Where do we need to keep this patient's blood pressure? Do they want permissive hypertension within a certain kind of range? We need to make sure that we have at least 2 IVs with some extension tubing. We should have fluids going, always normal saline. And why do I say saline? Because anything else, D5, LR, it actually worsens the patient's stroke. It increases the metabolic demand during the acute ischemic stroke based on the studies. Put on oxygen. We want to maintain the O2 sat greater than 95%. If they're post-TPA, this is tricky, then we have to maintain that their systolic is not greater than 180 over not greater than 180 over 105. So now we've got kind of a balance act as to where to keep them. And then if we look at their continuous blood pressures, we want to cycle the cup. If they're on the edge there, you might want to cycle your cup every 5 minutes to check your blood pressure. Again, nursing owns blood pressure. If it's too low, too high, we want to know why is that and what did we do about it. Does the family know what's going on? Have they been contacted? Have they been coming to see their loved one? We need to make that connection. We're not going to delay any kind of report to the receiving arm. We want to get that information out as soon as possible to who's receiving available. And we want to make sure that we send the images with the patient and any copies of any paperwork, particularly the tele-neurology consult note. I had mentioned earlier, it's probably a blur and it's very fair. The tele-neurologists do not have access to order entry, your thrombolytics and your antihypertensives. They make recommendations. The tele-neurologists do not enter typed progress notes, consultation notes. They will type their note and they fax it to the fax. And then the clerk will make a copy, give it to you for transfer and even admission here to the hospital. But you want to make sure a copy goes with the patient for transfer and or admission. And then a copy will get placed in the medical records bin and get scanned and uploaded to the patient's EMR. Okay. So our goal for door needle, I've got there 80% in 30 minutes and 120 minutes, 80% for door in, door out. So not an easy thing to do, but let me wind it back a little bit to the beginning. So at the beginning, what do we need to know? Most important, I'm always thinking TPA first. Are they eligible for thrombolytic? Last known well, time of symptom onset. Are they on an ACE inhibitor? Are they on an anticoagulation medication? Is their blood pressure less than 185 over 110? Am I going to have to treat that anytime soon? What if they're from a skilled nursing facility or a long-term care facility and they're coming from EMS? Do they have a pulse? These are some of the things that we think about. So it's all in the prep. Want to know that GFAST score. And if they're a walk-in, what were there or are there deficits on the BFAST exam? Okay. You'll also be assigned in HealthStream a couple documents just to read and review and attest that you understand them. And again, when you run into me or run into you, please introduce yourself. And likewise, I would love to hear your thoughts and opinions and perhaps any of your feedback. And I look forward to collaborating with you during the stroke alerts. Oftentimes, as you know, in other facilities as well, these can be challenging cases, particularly if there's language barriers or very high NIH stroke scale. But we have a great team here, very enthusiastic, and again, engage and over-communicate for the stroke alerts. That's the best way to close the loop before you head on out to a CT scan. Okay. Well, I want to thank you for your time and welcome. Again, my name is Karen Della Cuesta. I'm a family nurse practitioner. I'm a board certified neurovascular RN and board certified acute neurovascular practitioner here at O'Connor Hospital. And thank you for your time. And I hope you have a great rest of your day, night, evening, or weekend. Thank you so much.